Thank you very much. It's a pleasure to be here. And what I'd like to talk to you about in the next few minutes is my journey over the past 20 years being a physician, but also trying to help other physicians adopt technology. So I am a card-carrying nerd. I've been a nerd since before it was cool to be a nerd. In fact, in grade 5, my Christmas list did not include hockey gear. I wanted the Commodore 64. And it all kind of started from there. Yeah. Yeah. All right. So fast forwarding to now, fortunately, thanks to people like Bill Gates and Steve Jobs, it actually became cool to be a nerd. So I was able to actually overcome all of those Darwinian barriers to reproduction. I was able to find a beautiful wife and have a daughter. So that's a huge thing for me. Espresso and green energy we mentioned before. I do have solar panels on my roof and I drive an electric car. And I am very, 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 very sad about the Trump election result. Let's see if this thing moves. There we go. Healthcare, technology, so the two together. This clicker is a little wonky, I have to say. There we go. So really having the two intersect is really what I find very interesting. I do a lot of work with guys that look kind of like this clip art, docs who are trying to figure out which way is up and be able to use technology in their daily practice. So my journey in healthcare technology, if I try and span from way back in 1996 down to 2016, you'll see that there's healthcare technology is on the screen twice, and that's because I think it's actually changed. The emphasis back when I started in my medical training was there was a bunch of folks who thought technology was really cool, and healthcare just happened to be a way that they could use the technology. And what's happened, I think, fast forwarding to 2016 is now we've actually got a whole bunch of really difficult problems to solve in healthcare, and technology just happens to be a very creative means to that end. And so what I found at the beginning of my training, wow, this clicker is really a lot of fun, I have to say. Okay, it's kind of like it wants me to point at that screen. Interesting. Okay, so back when I started my medical training, most of the docs I worked with were still trying to figure out which way was up. This thing called the information superhighway and the internet were actually still new concepts to them. And really just simple things like pulling down lab results for their patients was about as advanced as they got. When I started doing some work in health informatics, I did an internship at Harvard. I did a project called FACTS, which was called Finding Appropriate Clinical Trials for You. It's kind of neat. It was basically a way for physicians to match patients who had cancer with active clinical trials. So I did a lot of sort of grunting down in the underbellies of technology. I was doing XML and all this great sort of technical stuff. But in the end, what we found is physicians got kind of frustrated because it was difficult to use the product. You had to do a lot of manual data entry to be able to, for the system, to be able to tell what kind of patient you were dealing with and then match with the appropriate clinical trial. So that whole workflow integration thing didn't really work so well because the docs had to do too much work to get to the end product. The next thing I tried to do during my medical training and I was on the wards was I was doing a very early foray into mobile medical computing. I don't know if anyone's ever used a Scion before, but that's a Scion computer. And I was actually using that to make all my medical notes when I saw my patients. Everyone around the hospital knew me as this guy with the portable computer. And I had a little parallel adapter that I could plug into any laser printer and be able to print my notes. Kind of cool, but I also got frustrated in the end. Oh, okay, there we go with the clicker again, because it was just too difficult to get my work done day to day. I'm a gastroenterologist, so this is the inside of a colon. The next thing that we did was we did some research on capturing digital video segments of person's colonoscopy. Now, this is not to sell the DVD at the end as a souvenir for $30, but actually was to improve quality. It was to be able to prove that the colonoscopist got to the end of the colon and saw the entire lower gastrointestinal tract. So kind of cool, and come on, clicker, there we go. Our patients thought it was pretty cool, the doctors thought it was pretty cool, everyone was pretty happy, but it took extra time, it added complexity to the procedure, and so again, we sort of ended up with this frustrated physician icon that's I should be showing for myself for this clicker right now. But anyway, basically docs got pretty frustrated with that too. So fast forwarding sort of halfway down the last 20 years, things started to change a little bit. I was hired at North York General Hospital as a clinician champion to do computerized provider order entry. There we go. So basically the idea is to translate physician very difficult to read handwriting to a perfectly legible and easily transmissible medium electronically. So We've just lost all of our screens. I think he just kicked out the display. You see what I mean about technology sometimes being more of a frustration than that's okay. I think I can just keep going. The pictures will come later. But anyway, with CPOE, at first I thought, okay, well, basically I'm just applying technology again. Am I going to end up with a bunch of frustrated physicians again? Possibly. But what I found along the way, actually, is that the healthcare environment was changing. And around the time that we were implementing the CPOE, there was a shift where the Canadian Adverse Events Study came out. So in 2004, Baker and Norton presented a study that showed that almost 24,000 patients in Canadian hospitals every year die from preventable errors. So quality and safety suddenly became a really important focus for hospitals in particular. Secondly, there were some funding shifts. So we were having hospitals being cut on their healthcare funding. That's continued to happen for the past 10 years. And in addition to that, there's been a shift from a global budget, which is the way hospitals used to be funded. Basically, you say, well, you treat 400,000 citizens, you get this number of dollars, congratulations. And they changed it to performance-based funding. So now hospitals had to prove that they were actually providing quality care, evidence-based care at the best possible value in order to get their funding. And so the question was, could healthcare technology actually become not just a whiz-bang gadget that happens to be applied to healthcare, but rather, these are difficult healthcare problems, can we use technology to solve them? And around that time, I realized that CPOE would be a very good way to do that, because the research shows that the most expensive tool in medicine is actually still the doctor's pen or keyboard, as the case may be. The way that physicians make clinical decisions has huge downstream impact to cost utilization in the system and also what patients are exposed to. And so it turns out that clinical decision support, together with CPOE, can actually be a very powerful agent to improve care, reduce costs, and improve quality. So it was the idea of the computer system now not being a passive communication device, but actually being a partner in making clinical decisions with the physicians at the point of care. Now that sounds really cool, but physicians are not too inclined to accept that type of technology. Physicians tend to be quite autonomous, and they don't really like changes to their practice. I know because I am one. So I had a tall order to try and get physicians to adopt this idea that a system would be able to help them make decisions for their patients. So what did we do? Well, as we were trying to get physicians to adopt this technology, we had to do a lot of workflow analysis, really hone down the workflow to try and make it as efficient as possible so that the system didn't get in the way of what they were trying to do. We had to listen to We-FM, so what's in it for me? The docs wanted to know, at the end of the day, if I'm going to make this big change to my practice, what's it going to do for me? How's it going to make my life easier? We needed this to be a team approach, so that the idea of we rather than us versus them. So it's not the information technology department doing something to doctors, it's doctors and the informaticists working together in the same room to solve the same problem, get the deep knowledge of the people who are doing the work on the front line, and build that into the design and the workflow of the technology. And then lastly was to get the wow factor. So we had to do some marketing. And in hospital projects, that's actually kind of unusual. Most of the time, there isn't a lot of marketing. But we actually hired a marketing firm to come in and create these images of superheroes. And these are actually people who work at our hospital, that we stuck comic versions of people's heads on superhero bodies. We're not actually all that buff, but. And then we put, where's the money? So we actually put in the posters that we posted, we put evidence from the literature that showed that these systems actually save patient lives. So in the end, although I was very afraid as to what might happen with this adoption process, because it was very difficult to do, even more difficult than this clicker, believe it or not. I'm going to be completely honest, full disclosure here. I was actually on a treadmill because I was having chest pain before this system was turned on. Fortunately, it was nothing serious. It was all just anxiety. But actually, we did achieve some pretty remarkable stuff. We got 100% of physicians to use the system, and what you can see here is the transition between paper and our CPOE and clinical decision support system. The red line, which is a little hard to see, and I don't have a laser here, but at the number 100, that's the national average of the number of preventable deaths that happened in a hospital. And you can see that before we introduced this system, our hospital was worse than the national average, and since we've turned on the system, we've been consistently, every 6 months, well below the national average of preventable deaths. So we're actually second best in all of Canada in terms of preventable deaths being, or deaths being prevented in our hospital. So I thought, great, cool. Thank you. So I thought, okay, great. So we've done this in the hospital. I didn't die. Let's go and do a startup. Let's really put the pressure on. So now I'm going to tell you a little bit about Agent Plus, which I tried to apply the same lessons I learned on the first go around to this product. So we partnered together. We created a company called Plexus Interactive, and Plexus is actually a company that's designed to work with clinicians on the front line to solve relevant healthcare problems. Part of the issues with the mobile healthcare space right now is there's over 165,000 healthcare apps, but only about 36 of those are comprising 50% of the downloads. So there's a whole bunch of apps that are just sort of lying around and aren't being used, and nobody wants yet another app that solves a problem that nobody wants to actually solve. You don't want a solution looking for a problem, right? So we wanted to pair directly with physicians to find, and other clinicians, the best problems to solve. And Identos is a company based here in Toronto, which does a mobile security. Basically, it has an SDK which allows you to build mobile security directly into your app so that you can store PHI on your device with no concerns about privacy and security. And so paperwork still abounds in 2016, believe it or not, in healthcare. There's still a lot of paper. And when we looked at pain points that really people find difficult, especially physicians like me, one of the big ones was medical billing. Medical billing is a very time-consuming process because in Ontario alone, there is a 750-page billing schedule. Nobody wants to carry that around in their pocket. Billing agents are expensive, and it takes about 8 hours a month of data entry just to get paid from the government. So what we wanted to create was basically an experience that right on your phone, you've got the entire billing schedule that you should be able to, in 30 seconds or less, complete your claim and move on. So what challenges did we have to solve? Number one was the whole piece of security. So we could have built an app that was based on a cloud-based server. The problem with that is a non-native app experience tends to be slow, it's clunky, it's not designed for a mobile interface, and physicians won't put up with it because they're very impatient people. The second issue is that there's a lot of dead zones in hospitals, and I don't mean the morgue, I mean cellular dead zones. And so we need to find a solution that works even if the phone is offline, so a web-based server solution won't do that. Thirdly, we need to find a solution that allows us to work, that the physician or other user can authenticate and still be able to work offline with cached keys even if the device is not currently online. So, wow, holy cow, this thing is really sensitive. Okay, I just went forward 5 slides without even looking. Wow, seriously. Maybe I could just ask you to, yeah, how about you just, Jared, thank you. Okay, next slide. I'm just going to say next, that'll be easier. Thank you. So, solving the challenge of simplicity. So this was the other issue. How do we take a 750-page billing manual and make it a 30-second experience and make it very easy to do? That turns out to be really tough. Basically, we had to engage a bunch of physicians up front to be our alpha and beta testers, to be people who were engaged in the design of the product as we worked. A lot of rapid cycle testing and iterative development, agile development to really make that product as refined as possible. And the other thing we learned is don't worry about perfection, because you're not going to get to perfection. If you keep trying to get your MVP perfect, you're wasting time. Get it out there, get people using it, and you're going to find that perfection is not what you thought it was on day one anyway. Next slide, please. So we really wanted to disrupt the space here when it came to medical billing. And that means a big impact to workflow. So that presents another challenge. Next slide, please. Which is how do we get people to have a really efficient workflow? One of the things we did was we used optical character recognition combined with a live link with the ministry database so that the clinician can basically scan a picture of the patient label, and within about 3 seconds it automatically corrects all of the information, all the demographic information that's needed for billing. So that was a huge win. Next slide, please. And this is a picture of our version 1.0, which has been available since May. And we have docs in, I think, about 15 hospitals using the product already. So we've been getting some nice traction. Next slide, please. So what were the challenges in terms of getting customers? That's really the challenge that we face now. We do find that if we put this in front of about 10 docs, that usually about 2 of them will want to take the product right away. So it's just a matter of getting the word out. And once we get docs on the platform, pretty much all of them stay. But we have the barrier of disrupting existing processes. So most docs have already figured out a way to bill. They've been doing it probably for 5, 10, 20 years. And it's difficult to get them to change to something new, even if it's obviously easier for them. So that's the first challenge. The second is that switching over to a new billing solution requires remembering government passwords and all these sorts of things that take extra time. And a lot of docs don't even remember their password. So how do we help them through that? So really what we tried to do is modify the app to be able to make it easier for docs to bill even if they don't have all of their information completed. And that we do a lot of ongoing communication, both high touch with our billing agents, but also with automated solutions. And the lessons that I learned from my hospital experience were that you really need to align your solution with the values, goals, and needs of your users, that we have FAM idea. Meaningful communication. So the best way we found for marketing is actually peer-to-peer, doctors talking to other doctors. And then the value adds, so we've started to do seminars to help people learn how to do billing better. Those sorts of value adds tend to attract people as well. Next slide, please. I think we're just about done. So in summary then, next slide. If we put all those things together, there's lots of opportunity in healthcare, lots of different things that are ripe for disruption, because basically technology today is still new in healthcare. It hasn't been applied in most areas, and there's still a lot of workflows there that have been the same for the past 40 years. But the trick is finding the problems that really need to be solved, because there's a lot of things out there that actually people don't care about. So you need to get and talk to your users, your clinicians, your patients, and find out what really matters to them so that you can find the right problems to solve. Once you find the right problem, you've got to constantly re-engineer your workflows and hone those workflows so that you get efficiency and value out of them. Work in partnership with your customers. And then inspiring adoption is a really big challenge, especially we found with physicians, and that requires a lot of peer-to-peer communication, high touch, and appealing to their values and needs. So like next slide, I think that's the end. Thank you very much. I'll take questions.
So if there's any questions, please feel free.
It can be technical, personal, whatever you like. I'm an open platform.
What did your first MVP look like?
The first MVP, so I was the first guinea pig because I still practice. So me and about 6 or 7 other physicians were using that. We have an interface designer on our team, so we did a lot of wireframing. So to be honest, the overall workflow and the general look and feel of the app was pretty similar to how it is today. Most of the refinement that's gone on since the MVP has been a lot of those little tweaks to the data behind the workflow and shaving off some of the steps to make it faster and easier for people.
I'm just curious to know more about the peer-to-peer marketing that you're doing, because you obviously have a full-time job being a
CMIO, yeah,
at Northrick General. So I'm just curious, like, how do you engage peers to push the information out?
Sure. Yeah, peer-to-peer marketing, I learned this from my hospital experience that the best way for a physician to receive a message is from another physician. In fact, if you got 2 people to stand up and say the exact same thing for 3 minutes, one person was from the informatics department and the other person was a physician, the physicians would only hear what the physician said, even though it's the exact same message. So what we've learned from that is for things like Agent Plus, referral program works well. So if the doc loves the app and they hand it to their neighbor and they start using it, we give them free billing. So that's been very helpful for us. Also having things like billing seminars has been very helpful because you've got a doc standing up and saying, hey, here's my pain points with billing, here's how we solve them, and here's some ways we can find to increase your revenue. So people like that as well.
What was your biggest challenge building the app or being a founder with a startup? The biggest challenge for me has been that I have at least 2 full-time jobs already. I'm a practicing physician and I'm a CMIO. So a lot of this work was being done in the evenings, on weekends, 3 in the morning when you wake up and realize Trump won and you've got some time on your hands.
you go and do some work. So, but it's great to have a team. We have a really good team that's working full time, and I'm just really helping facilitate. So that's number one challenge. And the number two challenge, I think, has really been the marketing. Like, we have a good product. It's the challenge is getting the word out there. Physicians are very tricky to market to.
Is there an incentive on the receiving side from the ministry to, does it help them in some way that would help them also add in encouraging the use of the application?
Thanks. So the question was, on the ministry side, is there any incentive? Not really. Actually, probably the ministry, this is off the record, but they would probably be happy if physicians didn't bill anything. So we're making it easier for them to bill, probably not what the ministry wants. But in all seriousness, I think one thing that is good about our type of product is you're removing several steps from the workflow. So the billings are more accurate, which means there's less rejections, fewer rejections, which is good for the ministry because it's less things to chase down the road.
So currently telemedicine solutions aren't included in the billing in Ontario. So what are your thoughts on like overcoming that challenge moving forward, and how that could impact like patient engagement and patient outcomes?
Sure, thanks. So the question was around telemedicine and how it's not necessarily in the schedule of benefits. Well, there are some telemedicine codes now. In the last year or two, there are some, but you're right, there are very few. The schedule of benefits, of course, is out of the hands of little startups like us, and it's really up to patients to advocate for, I mean, certainly telemedicine can save a lot of time and money for the ministry and for patients, and so listing more services in the schedule of benefits in that vein, I think is really important because it's actually going to save everyone money down the stream. So it's a matter of people like all of us writing to their MPPs and saying, hey, we want more. It's, you know, in Toronto, it doesn't really make as big a difference because people are already centrally located. But I think if people out in the northern communities, for example, would do more of that advocacy, we could get more things listed.